Should I begin now, or like, are we waiting for more? Hello.
Sir, we'll start by 2:05.
Okay.
Next 2 minutes we'll wait.
Sure.
All right, I think we will start because people are continuing to join. So, a very good afternoon to everyone. I hope everyone is doing well. Hope exams are going well. And also, I hope you've had your lunch. We welcome you all to the Case Club third session under the CliniqOn series. And this session will be presented by Dr. Vinayak Mishra, who is in pathology side and he has completed his undergraduation. A very warm welcome to you, Vinayak, sir. And
Thank you
before we
so much.
begin, hopefully everyone has gone through the PDF as per his instructions. So, Vinayak sir, you can take it forward from here.
Okay. Thank you so much, Mansi and group, for giving me this chance to discuss these things. So, so I have made things very simple and short. Usually, this is a very difficult topic dealing with neurology, but here, like, I have made it very much simple so that, like even if you don't have any medicine background knowledge, then also you can do it. Just yeah, sorry about that. So let's begin. So this is the first case, and so here we have a 55-year-old man who is a known rheumatic heart disease patient, and now he has been with limb shaking, headache, and loss of sight in his right eye since the last 30 minutes. So it is a very uh, like a short-term symptom. And now he was seen by a doctor after 40 minutes, and he found nothing wrong with the patient. So like at that time, after 40 minutes, there were no symptoms with the patient. And then the next day, they did a CT scan or whatever scans, and they found nothing wrong with the brain. So what do you think is the analysis here? You can, I think, like send on the chat box. Is there an option to send it like here? Or you can like speak it out as well. So what do you think is the diagnosis in this case? So since these symptoms were just for 70 minutes, so like just for 30 minutes plus 40 minutes, so this was just for 70 minutes. This so this is a, a transient ischemic attack. Basically, it means that there was some focal neurological deficit because of some blockade in the brain blood vessel, but then it got resolved like, like on its own. So that's what it means that there was some lesion, but now it is fine. So this usually happens before a, a stroke. So this should be taken very much seriously because it is said that after having this kind of a disease, your chances of like having like stroke in the next 6 months is very high. It's like fivefold. So this is a diagnosis. The next thing is it definitely a vascular lesion? So when you now think about it, so like is it a vascular lesion, like I said, or like is it can be uh, like, like something else like a migraine or some brain like a tumor or something else. What do you think? Just if you can just speak it out or just write on the chat box. Is it definitely a vascular lesion or should you have a broader differentials? The thing is that see, the most difficult part of a history is a negative history. So, like, unless you don't have a broad sense of differentials in your mind, your negative history won't work. So, like in this case, it is mostly a vascular lesion. Okay, it's a most likely, but still, you should have like think about something else because you need something for the negative history. So, like, what else can this be? It can be a migraine. Like, if you know, because here the patient has headache. Headache with loss of sight can be migraine. It can also be the acute glaucoma, because glaucoma also leads to a very severe headache with loss of sight. What else can this be? It can be vasculitis. It can be like optic neuritis because that can also lead to headache and loss of sight. So this is how you differentiate. You will have your negative history that I have ruled these things out. So when you are saying your negative history, so this is what you mean that I have ruled these number of different diseases from my list. Now the a third one is can I localize it? So it is a bit difficult to localize it because the symptoms were very vague. There was like headache, which can be with like any disease. And loss of sight is a very, like, it can like help you to localize. So loss of sight in the right eye, it basically means that there is something wrong with the right eye. And for a vision loss to happen in the right eye, there can be two types of lesions. It can be a vascular, or they can be something wrong with the nerve supply. So the vascular supply of the blood supply of the right eye is a ophthalmic artery. The right ophthalmic artery, which is the first branch of the ICA. So if there is a thrombus in the ICA, let me show you. So this is the ICA. This is the DSA. Like this is called as a CT angiography, which you will take. So this is the most. This is the junction where the CCA bifurcates. So because of this bifurcation, there is a lot of friction. There's a lot of turbulence here. Because of that, this is a very likely site for a thrombus formation. So mostly what is happening here is that there is a thrombus at this junction, and from that thrombus, a small, like an you can say like a small thrombus embolus breaks off and goes ahead to block the right ophthalmic artery, which is the first branch of the ICA. And because of that, now we have this disease. That is, we have this vision loss. So this is how we localize, and that. So this is how we localize that. First, we have to find where is the lesion, and then we have to find out what is the lesion. It is a vascular, or is it a nerve damage, or is it something metabolic? So this can be because of something like glaucoma or vasculitis. So you have to rule that out. Now the fourth one is that, is it like always feasible to differentiate between like anterior and posterior circulation strokes? So as you know, like brain gets blood supply from two things. One is the like anterior side we have the ICA, on the posterior side we have the vertebral arteries, the vertebrovascular system. So mostly, if there is a block in the like anterior circulation, it will lead to some damage in the brain cerebrum, the gray matter. But if there is some lesion in the posterior vertebrovascular system, it will lead to some damage in the uh, brainstem or cerebellum. So it is mostly white matter lesion. So usually it is not difficult to differentiate. I will just show you a table in which you will find out that there is clear-cut differentiation. But the thing is that sometimes it is very much difficult to differentiate between the two. For example, like here, we have a vertebrovascular system, okay, like an aneurysm. It was somewhere. Yeah. So this is the table. So like as you can see here, that mostly it is very like simple to differentiate. If it is an anterior circulation stroke, it will mostly happen on just one side. If it is a vertebrovascular stroke, it will happen on both sides. It will most likely affect the brainstem. It can lead to dysarthria, dysphagia, vision loss, or it can be mixed pattern also. This is very like important to differentiate, because this is like how you will go about it. When you like order the CT angiography, you have to say that which arteries did you need to see. So then, so For that, you have to tell the radiologist that I suspect a lesion in this artery. Then only they will see that. So, and this is also like asked in your vivas very frequently, that how do you differentiate which is the, or rather, where is the lesion? Whether it is like in the like ICA branches or the VBA branches, the vertebrovascular artery. So now let me ask you that, like, is the two circulations like completely exclusive, or there is something that joins these two? Is there a blood vessel that joins these two circulations together? Is there something like that in the brain? Yes, it is a posterior decombinant artery, but that is just one artery. It's actually the circle of Willis. The circle of Willis is the one which joins these two together. So that is why if there is a blockade in the like anterior circulation, it will be resolved by blood flowing from the vertebral system. So that is why this is like a defensive system we have, and for that you need to know the basic structure of the circle of Willis, where is it located, and like all that. So let's move on to the next one. Yeah. Yes. So this was the next question, that what joins the two. So it is not just the like circle of Willis. There are few other but smaller anastomosis. We are They are known as leptomeningeal anastomosis. But those are very much minor. So like if you don't know that, it's fine. So just know the circle of Willis and like how it functions, and that's it. And so the next one is, what's the discharge premature? What what other tests would you do? So just tell me what you think. Which test should we do in this case? So this is something which is like very much newfound with both stroke and GA, that you have to find out why has this happened, and for that you will have to do a risk factor management. For example, we have to rule out diabetes, hypertension, or any other drug history, or like smoking history, and so on. So that is one part, and then you have to find out where is the thrombus, because now your diagnosis is that there is most likely a thrombus in the ICA. So you have to find that out. So which test will you use to see whether there is a blockade in the right ICA? That is Doppler. You will have to use a Doppler ultrasound that will let you know whether there is any blockade in the right ICA. And another thing is that in the history, you will see that this is a patient of rheumatic heart disease. So like even that like can lead to a thromboembolism, because in rheumatic heart disease there is mostly like atrial fibrillation, and because of that there can be a thrombus in the left atrium, and that can dislodge and go and block like any of the brain's blood vessels. So for that you will also have to do a 2D echo. The echo will let you see whether there is any thrombus in the left or right atrium or not. That is also very much necessary. And then there are some routine tests. For example, to rule out diabetes, you will have to do a fasting blood sugar and like an HbA1c or no, there are so many different tests. Also, one very much like important is do a fundoscopy because you want to know whether that right blindness is like has left something like permanent or not. So you have to find that out. So doing a fundoscopy is mandatory. You will have to do a fundoscopy to find out whether there is any like permanent retinal damage or not. So let's just say that like in this case, when they did a CT scan, they found that there is a vein or let's say left or maybe right cerebral infarction. So they found that on the CT scan. So will you still say that this is a TIA or like has the diagnosis changed? If you know what you think if we have some CT scan or diffusion weighted MRI findings. So but there is what the symptoms have resolved in just 70 minutes. There are no symptoms now, just something on the CT scan. So will you still label is that it as a TIA, or now will you say that it is something else? Mostly it is not a TIA anymore because the definition of a TIA has two parts. One is that there is resolution within 1 day. Another thing is that there is no findings on the CT scan or like any other brain scan, whatever you do. So like unless these two are satisfied, you will not label it as a TIA. That is very much important because this is mostly like asked in your bypass that how will you differentiate between the two. Okay, so let's move on to the next case. Next one is a very much a typical case. This will be definitely in your in your like exam. This is most likely to come because now this is a middle-aged man with hypertension, diabetes, and smoking. So like he has all the risk factors for a stroke. And now he has come in the morning with weakness in his left side of the body. He also has drooling from his mouth. And when you examine the patient, there is a zero power in the left hand and like 3/5 power in the left leg. So 3/5 means that his left leg can move like against gravity. Okay? And this DTR or deep tendon reflexes are higher. The plantar reflex is absent in the left foot and downgoing, which is normal in the right foot. There is no sensory loss. Dysarthria is present while dysphagia is absent and the BP is high. So the first thing is what is the diagnosis? So please just write what you think and like whenever you say the diagnosis in your viva, so like it should be in this way. Like is there a lesion? Where is the lesion and what do you think is a lesion? Sometimes you don't know what's a lesion. So like instead of saying just one thing, you can say that these are my differentials. So what do you think here? What is the uh, diagnosis here? Please let me know in your chat box. Yes, Yemen lesion is one. This is a good answer. So human lesion, definitely. So that is what is the lesion? It is a human lesion. And now you have to narrow it down. By human, it can mean from brainstem, spinal cord, cerebrum, like anywhere. So where is the lesion? Where do you think? Internal capsule, got it. Like great answer. Just saying directly like internal capsule is actually very much brave because you don't know whether it's a lacunar infarct. Lacuna means the like capsule. Okay, so this might be a lesion in the brain cerebellum also. So it is not like easy to say whether it is directly a lacunar infarct or it is a cerebral lesion. So still, we can actually guess from this that this is most likely a lacunar infarct or a, like an internal uh, like capsule infarct. So that is the right answer. Hmm. So next thing, so yeah, just a bit on this. Uh, I'm missing something. Yeah, is the relation? Where is the relation? So where is the relation? It is in the right internal capsule. Okay. What is the relation? It is most likely vascular. Okay. This is also like it might be a vascular, but you have to now think now. Like always think about your differentials. So what else can it be? Okay. So leave aside vascular, leave aside thrombosis and all that. What else can it be? Now this patient has a very long history of smoking. He might have lung cancer. So like can lung cancer lead to stroke? Think about it. Yes, it can lead to stroke by causing metastasis to the brain. Another way it can lead to stroke can like anyone tell me. So this is a one way, this is like most likely way. But there is one more way. I think it is a bit difficult one still. Think about it. What what happens with like any severe cancer which you see in like house like MD cases, paraneoplastic syndrome. It's called PNS. So like like with any severe cancer which is like disseminated, there can be a like there can be like antibodies formed which can go and damage the brain, and that can also lead to such lesions. Then it's called as paraneoplastic syndrome or PNS. Okay, so yeah, this is one thing. But mostly, why like am I not thinking about brain tumor? Because brain tumors are not this sudden that one day you will wake up and like have it. Okay. Now, do you think that brain tumor like, can lead to such a sudden onset stroke? Think about it. Like, like, is there any way a brain tumor can cause a sudden onset stroke? What can happen to the brain tumor that like it can go very much big or it can grow very large and cause a stroke? See, brain tumor it has a very weak structure. Okay, its blood vessels are very much narrow. It's very much fragile, so they can break off at any time, and they can be bleeding inside the brain tumor. That is called as apoplexy, APOPLEXY. So when there is bleeding inside the brain tumor, it can grow big very fast, and that can lead to sudden onset stroke. But of course, that is rare, but we will still think about it. We will still rule it out in our uh, in our negative history. What else will you think about? So always think about or rule it out in your negative history, infections. Okay. So like infections that can cause a stroke, we have very few. We have like HIV, TB, nocardiosis, and actinomycosis, and so on. But these are very rare. But so we will focus on TB. So whenever you are taking a negative history, you have to rule out a TB as well. That there is no family history, there is no long history of cough and so on. So you have to rule that out. Can anyone tell me how can TB cause like a stroke? What is richest focus? Called as rich focus. So when TB goes like into the brain, mostly it is at the base of the brain. So this is the brain just at the base of the brain, where there is all the white matter or the circle of Willis, blood vessels. So there is where TB will make its focus, and that is called as rich focus. Like we have a gone focus in our lungs, we have a rich focus in our brain. That is at the base of the brain. So, like I said, at the base of the brain, there is like everything. There are nerves, blood vessels, like everything. So TB can just like infect these blood vessels and cause vasculitis. And via that vasculitis, it can get blocked and lead to stroke. So TB can also lead to stroke, and this is a very much like important like question. They will ask you that how can TB cause stroke. So you should know that there are like 3 4 ways that it can cause some like okay. So one way is TB of course, like TB vasculitis. Another way is that, like brain tumor, TB can also form a mass in the brain called as tuberculoma. So that is the second way, and the third way is that TB can cause hot spine, but hot spine is something different. It will not lead to so like it is of the spinal cord, so not in the brain, but still it is something that you should know. So these are the 2 ways like how TB can lead to stroke. Same goes for HIV. HIV can cause CNS lymphoma. Okay, and CNS lymphoma can also lead to a brain tumor-like thing, which can cause a stroke. And like HIV can also lead to sinus thrombosis because and that can also lead to a vascular defect and stroke. So always rule this out. How will you rule out HIV in your negative history? What will you ask for to rule out HIV? Can anyone tell me? For TB, you have to ask all those usual things: weight loss, cough, long history of fever, no family history, and so on. What will you ask in your negative history to rule out HIV? Sexual promiscuity. You have to ask the patient. So you have to like ask the patient about this. Mostly the profession of the patient also matters. If the patient has yes multiple partners, so that is also known as sexual promiscuity. So like earlier, we used to like ask that for syphilis because syphilis can also lead to stroke. So for both syphilis and like HIV, we have to ask this. So we have to like ask this and see what you have mentioned that persistent diarrhea, lymphadenopathy. This is like this can be happen like also there, but this is something which can happen in a lot of diseases. So that is why it is not something very much specific. That is like if you rule this out, you are not ruling out just HIV. So that is why I just ask for a negative history. And uh, lymphadenopathy is something which we find on GE, that is general, like on a general like examination. That is not what we find on negative history. Let's move on to the next thing, next bit. If you are like if you have any doubts in between that, if something seemed difficult to you, then just type it out. I will look at it. So yeah, this is a good one. That which side of the mouth is the patient most likely drooling from, left or right or both? Please answer on the chat box. Right side. Okay. Right side. Okay. So you should know that if there is an internal capsule infarct, as you are saying, okay, so that will also like involve damage to the. It will be like also a UMN lesion for the facial nerve. Now, a facial nerve is a lower motor neuron, and its UMN supply will get damaged. So they will be just of the and like as you know, the like the upper part of the face has a dual nerve supply. So there will be no deficit in the forehead, in the buccinator muscles, and so on. So, like the upper part of the face will not have any deficit because it has a dual or bilateral nerve supply. But the lower part of the face has just contralateral nerve supply. So if there is a right side internal capsule infarct, then there will be a left side UMN lesion of the face, which will be left lower. So the left lower means that the what is that muscle called, which we use for smiling and what's that called? Depressor anguli obliques or something like that. Okay, so those muscles will not work, and because of that, they will be drooling from the left side of the mouth, not right, because drooling will be from the same side of the mouth. Because in the right side, you have muscles which are working well, so that will be like it will like keep lips shut. But in the left side, those muscles are not working, so you will drool from the left side. Okay, this is also very much important because see, now suppose you go to the like exam hall and you see the patient, that this patient has left-sided lesion, sorry, left-sided weakness in his hands and legs, but he's drooling from the right side of his mouth. If that is happening, then your entire differential and everything will change, because that means that this patient has brain stem lesion. This this patient has a right-sided facial nerve lesion with a left-sided CNS lesion of the cerebrum. So you have to look at that. So if the patient is drooling from the same side as his weakness, then it is good news for you, because brainstem like strokes are very much difficult to diagnose and just do it like so. Mostly they will have drooling from the same side of the weakness. So next question. No, no. Yeah, next question. you have noticed that there is more weakness in the upper limb than in the lower limb. Why? Why do you think that is the thing that we have more weakness in the like hands and less weakness in the legs? Why do you think that is happening? Just try to think about it. You will see a lot of stroke patients that they can walk, but with, of course with some limp, but they cannot write or just like use their hand for something useful, but they can walk with the limp. So mostly their lower limbs will function well or not well means it will be like fine, but their hands will be like useless. Why does this happen? That their legs are mostly working, but their hands are not. Why do you think so? Anything? Just think about it. Think about the brain homunculus. Primary protein cortex. So the thing is that actually the if you see the homunculus, the legs are at the top of the cerebrum. Okay, so legs sometimes has dual blood supply. It has blood supply from both the anterior cerebral artery and middle cerebral artery. So because of that, sometimes what happens that the legs will recover very fast, and because of this dual blood supply from both the anterior cerebral artery and the middle cerebral artery. So because of that, you will see that most patients will have fine legs. They can walk, they can go to the bathroom, but they but they but their hands will be like useless. So you should know that, and like don't be like stumped. You see, okay, that this patient has a like working leg. So like, is this a mono paresis? No, it is mostly a hemi paresis. So next question, you were expecting an extensive plantar response on the left foot. That means you stand. Why didn't you get it? What to do? So mostly, like in the same side of the UMN lesion, the same side of your weakness, you will find a Rabinsky sign, which is an extensor response of the great toe in the left foot. But sometimes you don't get it. And this is very much important because in your Viva, they will just ask you to show this. They won't ask you to show that that power and all that, but they will definitely ask you to show how to do a Rabinsky sign, how to get a Rabinsky response. So why and what to do? Think about it. Okay, just tell me what should you use to get a to do a plantar reflex? What should you use? Whether you should use a pen or a pencil or something else like uh, what can I do? Like a nail or pin. What should you use to like elicit a plantar reflex? Mostly we use the like hammer that hammer what's it called? A Kroner's hammer. We have that black one, and we just do it from the lower end of that hammer. What is the best thing that you can use? It is your room key. just take your key or your bike key or like something else because it is the thing that thing which you use for this reflex. It it should not be sharp. It it should not be something which can harm the patient. It should be blunt and it should be a bit soft. And for that, the best thing that you should do is use a room key or just like any key, okay, a big one, right? And you have to do it very slow, not very slowly, but in a very like a smooth way. Just think that from going from the sole to the uh, toes, it should take at least 2 seconds. So we do it usually fast. So if it's less than 1 second, don't do that. Uh, Give it time. Okay. Like it should take at least 2 seconds for the whole movement to happen. So mostly you have to learn or just see videos from YouTube that how to do it right. Because that is something you will definitely be asked. This dysphagia, dysarthria can assist for both if the patient has dysarthria. So, what is the difference between dysarthria and dysphagia? Simply speaking, dysarthria is a lower motor neuron element lesion, whereas dysphagia is a human lesion. Dysphagia or aphasia has two types, Broca's and Wernicke's. Broca's is motor and Wernicke's is sensory aphasia. Broca's means that you know what to say, but you don't know how to form that word. So you will see that Broca's aphasia patients in the ward will be depressed. They will be like silent. They won't talk to you. They won't even look at you when you like take their case. They won't speak anything. Whereas Wernicke's aphasia patients, they will speak a lot, but they won't make any sense because they know how to speak. They know how to form words with their mouth, but they don't know what they want to say. They have lost their understanding of the words. This I'd say is something like you have to just think about it that just try to speak without moving your tongue. Just like hold your tongue, don't move it, and just like try to say something. The sound you make is very much similar to what dysarthria is. You have to differentiate because dysarthria is a lower motor neuron lesion, whereas dysphagia it means that there is a cerebral lesion. So if this patient had dysphagia, this would not be a lacunar infarct or an or an internal capsule infarct. This would be a cerebral infarct. Okay? So you should read about it more and find what are the different or various things that can cause dysarthria. Like as I said, it's a lower motor neuron, so it can be like happen because of facial nerve lesions and vagal nerve lesions. Okay, the next thing is very much important. This is the so mostly your viva won't go to the management stage because they don't have that. But if they go to your management part, this is the one they will ask. That now this patient's BP is very high. Usually, if you measure their BP, the patient with like stroke, their BP will usually be high. So should you like, try to decrease it and bring it back to the normal side? Just say yes or no. Should you to like now it is 180 to 110? Should you try to bring it below 140 90? Think about it. Yes or no? The answer is no, because the thing is that the BP which rises, it's a defensive mechanism. What happens is that now this is happening because there is less blood spread to the brain. So the brain, via a reflex mechanism, raises the BP so that so that there is more blood supplied to the brain. So never try to decrease the blood pressure in a patient with stroke unless it is very high, when it is more than 220 by 120. Okay. If it is below that, then it's fine. Just don't try to decrease it because it's a defensive mechanism. If you try to decrease it, then the brain's blood supply will fall even further, and the patient will worsen. Okay. Yeah. Okay. So another thing that I missed is this patient came at morning 6 a.m. What is that significance? Just know that most of the strokes which happen in the morning, like early morning, it's a thrombotic stroke. Okay. Mostly it is a thrombotic stroke, which we call it, it slowly develops. Okay. It is not like it is, it will develop slowly. The weakness which will happen, it will worsen step by step. So that usually happens when the patient will wake up and will find, okay, that I cannot move my hand, I cannot move my legs. That's mostly a thrombotic stroke. But if the patient says that, like, I was working, I was doing some heavy lifting and so on, and then it happened, then it is most likely a stroke, which is because of a bleeding, like uh, which we call as a hemorrhagic stroke. So you should know how to differentiate. A patient with a hemorrhagic stroke will be disoriented. He will have a very low GCS score. He will not be very much responsive. You won't find like all these signs with him. The patient will be very bad, very severe. But suppose if so this is how you will differentiate between a thrombotic stroke and a bleeding stroke or a hemorrhagic stroke. So next case is a bit a difficult one, so, but this is a bit personal because it happened to one of my relatives when she was in third year. So yeah, this lady had okay, so she had no other disease, no diabetes, hypertension, nothing. And just one day she had dizziness. They need to maintain balance while walking and double vision. And this was worsening since the last 2 days. Now she has developed difficulty in swallowing, and now she is drooling from the mouth. On examination, there is the pupillary response to light is fine, it's fine. But there is failure of right eye abduction and, a process of right eye, which means that there is drooping eyelid of right eye. Power in both the upper limbs is 4 by 5, means it is a bit lower than normal, but it is completely fine in the lower limbs. Deep tendon reflexes are fine, it is not high. Frontal response is also normal. There is no sensory loss. Romberg's test is positive and she has some cerebellar signs. What do you think is the diagnosis? Try to answer this one. Just go like, what is the lesion? Where is the lesion? Just say that, just try to localize it. Try to go like with the background of the symptoms, that what can cause failure of right eye abduction. Think like that and just backtrack. Where do you think is the lesion? Is it lower motor neuron or upper motor neuron? What do you think? So in the exam, you will have three different types of CNS cases. One will be like a stroke. Second will be a Guillain-Barré syndrome or paraplegia. It is a spinal cord lesion. And third will be a short case on Bell's palsy. It is lower motor neuron facial nerve lesion. So this is the second one. It's called as Miller-Fisher syndrome. Miller-Fisher is a rare variant of Guillain-Barré syndrome. Guillain-Barré is very much common, and it will definitely be risk exams because it is very much common and it is very easy to see. So Guillain-Barré syndrome is mostly an ascending process. First, your legs won't work, then your hands won't work, then you have breathing difficulties because your diaphragm won't work, and then it will go into the brain stem, like facial nerve, fifth nerve, sixth nerve, third nerve, and so on. So it goes from the legs to the head. But sometimes it rarely goes in a descending. It goes from the head to the legs. That is called as Miller-Fisher syndrome. And Miller-Fisher is a rare variant of GBS, and you don't need to know that actually. Just need to know what is GBS, what is Guillain-Barré syndrome, what is the management, how will you diagnose it, and what are the symptoms, what are the usual findings, and so on. So as you can see that the power in both hands is 4 by 5. So this means that this has begun descending now. It has now affected the eyes and all that, and now it is going down to affect the hands. So failure of right eye abduction means that there is a lesion in the right side sixth nerve, that is the abduction nerve, and ptosis of right eye means that there is a lesion in the right side third nerve, that is the oculomotor nerve. So this is how it affects. It is not very much uniform. It is very difficult to say that like, where it will go next. Okay. Sometimes it is very much severe. Sometimes it is very much mild. So mostly what happens is that it has a, a 2 weeks rule. In the first 2 weeks it will worsen. And then for the next 2 weeks it will remain the same. No response. No worsening and no improvement. But after these 2 weeks, it will start improving. So by 6 weeks, you will be done. Okay. So, but in some cases, it becomes very bad. There is some respiratory distress, and for that, we have to give some drugs. So the drugs we give is IVIG, that is intravenous immunoglobulin. Next question. Can it be the onset of MS? Yes, yes, it can. See, multiple sclerosis can also present this way. There is no doubt in that. And like MS, and she's a female, and like MS mostly happens in females, in young females. So she's of the right age and gender. So in your differentials, in your negative history, you have to rule out. You have to think about MS and rule it out. Okay, how to differentiate transverse myelitis from Landry-Guillain-Barré syndrome? So transverse myelitis is a lesion of the spinal cord, and Guillain-Barré syndrome is a lesion of the nerve roots. So one is UMN lesion, and the GBS Guillain-Barré syndrome is a even an LMN lesion. So then you have to just find out that how do you that you learn this in first year, that how do you differentiate between UMN lesions and LMN lesions. Just use that in UMN lesions, and both of them there will be loss of power. But in human lesion, there will be wasting of muscles. In human lesions, sorry, in human lesions, there will be no wasting of muscles, but in animal lesion, there will be wasting of muscles. In human lesion, the DTR, the reflexes, will be higher, but it will be absent, very faint in animal lesion. And so on, you will have to differentiate because these both will cause uh, bilateral lower limb weakness or paralysis. So you have to know that these are the two main main differentials of bilateral lower limb weakness. So this is if this the case is in your university exams, this will be the most definitive question in your diagnosis, that is this a human lesion or is this an animal lesion? So this is something you should know very well, that how to differentiate between the two. Diagnostic investigations, there are not much. GBS has no blood markers. It has some antibodies, but also those are like very much difficult to do because those are very much expensive. So mostly we do nerve, nerve studies. We call them NCS. I'll just type it out. Nerve conduction study. So in this study, what we do is very simple. We just like stimulate a nerve and then we check its response. So we use like electrodes and we do that. And if there is some, because in Guillain-Barré, what happens is that there is some antibodies which are formed against the myelin sheath. So these nerves are actually like well, they are functioning well, but they don't have myelin sheath. Because of that, their conduction has become slow. So, so if you do this nerve study, it will show that yes, that this nerve is still working, but its transmission is slower than usual. It is slower than normal. So that is how you diagnose Guillain-Barré syndrome. And management is just supported. It will go away on its own. You don't have to do anything. Just have to give supportive management, nothing else. But in some cases, it becomes very bad because of diaphragm weakness. Because of that diaphragm weakness, it leads to respiratory distress, and the patient might even need a mechanical or little support. And so the drug of choice is IVIG. The dose is 0.4 units per kg, and we have to give this for 5 days. So this is something they ask. So that is why I have mentioned it. It is known as IVIG. IVIG. IVIG is also being used for COVID now. So any doubts as of now, like anything, whatever you have found difficult or like very much like beyond your scope, just let me know. Then I will just move on to the last slide. Okay. So this last slide is on something different. It is not relevant to your mostly like examination or like even a syllabus. This something is basically how to read a paper. So what happens that we are told that we have to follow the evidence-based medicine, but we don't know what it is. And so we have this notion that it means that we have to read a lot of scientific papers and read their results and find out what they say. And then we have to follow that. Whatever these papers say, we have to follow that. But the thing is, it's not that simple. You have to know how to read a paper. You have to, so don't directly jump to the results section of a paper. You have to know how to read it, how to know whether this paper is valid and reliable. Because now there are so many papers which are basically betraying. They are based on false foundation. Like this one study which is now very much recent. This was done in IMS, Vinayak. This is a case control study, which is basically recommending the use of the drug ivermectin for prevention of COVID-19 infection in healthcare workers. And they did a very small study in their own hospital, and based on that, they have recommended its use like globally or like at least nationally. And it recently went well in the news, and also that like patients and like all of them they have like started like taking it on their own without like asking their doctors. So if you have read this paper, like, can you just tell me from like, yes or no that like, do we believe this? Like based on this, do we recommend the use of this drug for prophylaxis? Like should you now take this drug to prevent yourself from getting this infection? What do you think? So if you have read this paper, you will know that this is a, a case control study. And if you remember from biostats, like it is a very low level like study. It is not sufficient to recommend the use of a drug for a disease, whether for management or prevention. For to recommend the use of a drug for a disease, we need randomized trials. We need randomized studies, and this was not one of those. And this was just a simple observational study, and it has a lot of bias because this is just done in doctors. I'm just doing it on doctors. I mean, saying that like everyone else should take it. This is not justified. So this is basically based on like a small thing that I'm working on, that like how to teach people that or like how to make them more like woke woke or like aware of how to read paper, how to find their mistakes, how to find how are they trying to like fool you. Okay? Maybe like Ames Bhubaneswar might have received like a huge funding from these like from the makers of this drug. We don't know that. So you have to be a bit, I would say, negative. You have to be a bit negative and try to find out their faults. And then you have to see whether you should use this drug or not. Right? And I'm done now. Thank you so much. Is there like any other doubts or like questions you have? Do ask.
Any doubts, anyone? Oh, I think there are no doubts. So I'll conclude the session. Thank you, Vinayak sir, for such an amazing session. We at GMC Case Club are really thankful to you for giving us such a different perspective towards what practical exams will be like. And I'm sure this has helped all of us. Thank you once again for this session. Also, I would like
Thanks.
all our audiences to share their feedback regarding the session on the Google Forms that we'll be providing in the link below. And if you have liked our session and the previous ones as well and want us to conduct more such sessions, please let us know in the suggestions. Thank you so much. Thank you, sir.
Thank you. Yeah. Thank you, everyone. Bye bye.